And I'm also, my plan is to, I'd also plan to turn on the captioning. And right now I'm not seeing the option on the bottom of my screen, but I will pick that up after I have a moment to look into that after Vanessa begins her presentation. So I'm very pleased to introduce today's speaker, Dr. Vanessa Warner-Lang. Dr. Lang is currently a research associate in the Population Studies Center, and she's the project manager for the Michigan Contraceptive Access Research and Evaluation Study, which we'll be hearing more about today. And I've had the opportunity to work with Vanessa on this project for the past couple of years since she joined in 2019. And I just have to say that she is a phenomenal manager of a very complex study that involves sample recruitment among women in Planned Parenthood of Michigan clinics, and involves keeping track of our randomization to work sure that it's functioning correctly. It involves getting administrative data from Planned Parenthood clinics, as well as data sources from around the state. She's had oversight over our longitudinal survey. So it's just an incredibly complex study, and that it involves a lot of moving pieces. Vanessa's engaged with a lot of different actors all the time, and it's just a phenomenal manager and leader of the project, of the components of the projects that she's responsible for overseeing. So I just want to say that, you know, good science is in the hands of people like Vanessa, and she's done a fantastic job of making this what I hope will be a really influential study by maintaining its rigor through her really careful attention to study design and execution. So a little bit more about her background is that Vanessa received her PhD in sociology from Bowling Green State University in 2019. And her research interests are in sociology of the family, fertility, demography, and labor force participation. Her work on reproductive attitudes and sexual behavior has been published in Demography, Journal of Adolescent Health, and Population Research and Policy Review. And as I said today, she'll be speaking about MCARES. So I will turn it over to you, Vanessa, if you're ready to go.
Thank you so much, Paula, for that kind introduction. So good afternoon, everyone. My name is Vanessa Lang. As Paula said, I am a sociologist and family demographer by training, and I have research interests in fertility, work in family, parent-child relationships, and well-being. So my prior and current research interests really focus on studying fertility behaviors in the United States and the possible policy implications surrounding access to contraception for women and children. I should also say I have research interests in how the intersection of paid work and family is associated for individuals and couples, with a specific focus on relative earnings and work-family conflict. So since joining PSC, as Paula said, I've been working as the project manager for MCARES, which I'll be presenting on today, where I'm heavily involved in all aspects of the study. So I wear many hats. These include our data collection efforts and field implementation, our survey design and development, statistical analysis for the study, administrative data linking, grant writing, and beyond. So I'm thrilled to be here today, and let's get started. So today I'll be discussing our first paper from the MCARES project, and I'm excited to share with you some of our first stage results, which examine contraceptive use among low-income women in the United States. I'm thrilled to also acknowledge Martha Bailey and my co-authors Iris Veroni, Leah Bart, Paula Fomby, Jennifer Barber, Daniel Eisenberg, and Vanessa Dalton, who are all part of this paper. To go over an agenda, so first I'll be discussing the MCARES research design and also the motivation behind the study. Then I'll move on to our first year paper results on contraceptive use among low-income women. At the end, I'll leave some time to discuss my future research agenda and then move on to a question and answer with the audience. So here's a little bit of our project branding for MCARES. Martha Bailey is the PI of MCARES, and Paula Fomby, Jennifer Barber, Vanessa Dalton, Daniel, and myself are all collaborators. I should also mention that the findings and conclusions in this presentation are those of us, the authors, and do not necessarily reflect the views of Planned Parenthood Federation of America. MCARES is funded by the NICHD and Arnold Ventures, and we are in close collaboration with Planned Parenthood of Michigan, where we collect our data and enroll women into the study. And NORC out of University of Chicago manages our field management. So close to half of US pregnancies are unintended. These are estimates by Feiner and Zollner between 2008 to 2011. And unintended pregnancies are measured by either mistimed births, so births that occurred too soon for women. So they wanted to become pregnant at some point in the future, but not at that point in time. And also unwanted births. So women did not want to become pregnant at the time they became pregnant or at any time in the future. We can see large disparities in pregnancy by income in unintended pregnancy. So between 1981 to 2011, unintended pregnancy has disproportionately occurred among poor women. Today, it is increasingly concentrated among poor women, and we can see that these large disparities have existed over time. So while unintended pregnancy has been declining in recent years, we still see large disparities by income. So similar to results shown by income, we can see that a greater proportion of women with a high school education or less experience an unintended birth. We can also see disparities by race. So compared to white women have a higher percentage of unintended births, followed by Hispanic women. So what are some of the implications of unintended pregnancies? Why is this important to study? So 4 in 10 unintended pregnancies end in abortion, and 2 in 3 unintended births are funded by public insurance. So this places a burden on both the state and taxpayers. There's also a large body of evidence showing how unintended fertility is linked to poor individual couple and child well-being, including but not limited to intimate partner violence, union instability, and perceived and actual employment and financial outcomes, including a negative association with educational outcomes for women. So contraceptive use is a proximate determinant of unintended fertility. So what do I mean by this? So we have about 43 million women at risk of unintended pregnancy. And we can see that a large percentage, so 68%, have consistent contraceptive use. However, the remaining 14 and 18% of women at risk have either non-use of contraception or long gaps in use, or inconsistent use of contraception. So among that 68%, so those 2/3 of US women at risk of unintended pregnancy who practice contraceptive consistently only account for 5% of unintended pregnancies. So what this means is the majority of our unintended pregnancies are occurring among women who have either non-use or inconsistent use of birth control. We also see similar patterns of contraceptive use by education and race. So women with less education are more likely to use less effective methods, and compared to white women, Black women are less likely to use effective methods or no methods at all. You might be asking yourself, why don't women use reliable birth control or use it consistently? So there's a body of literature that suggests that ambivalent attitudes towards pregnancy are related to inconsistent use compared to those with a firm motivation to avoid pregnancy. There's also a body of literature showing how medical mistrust and discrimination, which is disproportionately experienced by Black and Hispanic women in the medical system, leads to inconsistent contraceptive use. Another reason has been, well, there's just not enough knowledge given to respondents about how contraceptive works. So there's inadequate physician and provider counseling. Third reason is, well, you know what, it's expensive. So while under the Affordable Care Act, for insured women, where it's mandated that their insurance must cover contraception, we still have a large proportion of women who are uninsured. And so while places like Planned Parenthood subsidize contraception, and so Planned Parenthood uses Title X funds, they still face high out-of-pocket costs for some of the most expensive methods. So getting a LARC, which means either an IUD or implant, which are the most effective methods of birth control, for the average uninsured woman, this can be really prohibitively expensive, costing on average $1,000 or more. So the goal of MCARES was really to test this third possible reason. So MCARES is the first to use a randomized control trial to test how and if the cost of contraception is a barrier to contraceptive use among low-income women. As described before, MCARES is a large-scale RCT, and there are two overarching questions that the project asks. So first, how does greater financial access to contraception affect women's choice of contraceptive method, and subsequently their future unintended pregnancy and childbearing? Second, and more longer-term goals are to look at how financial access to contraceptives affects other dimensions of women's lives. So their attitudes about the reproductive healthcare system, their physical and mental health, educational attainments, participation in public programs, and also the outcomes of children. So in this paper today, we're focusing on contraceptive method. And as you will see, this may have large impacts on unintended fertility outcomes. MCARES is designed with individual randomization of vouchers to cover the out-of-pocket costs of any contraception at Planned Parenthood for half of participants. We use within clinic randomization to account for provider differences, and this also helps with power in the study. I also want to highlight that our voucher that we give to women is good for any method of contraception available at Planned Parenthood of Michigan. So LARCs, pills, IUDs, shots, implant, anything a woman can choose to use the voucher for. So we do not restrict to LARCs, as has been shown in other studies. We also pay for the removal of the LARC device if the woman is unhappy with it within 1 year of them getting it. We're also going to be following participants over time, so going back 20 years and forward 30 years to compare outcomes for those who received a voucher, so the treatment group, to outcomes of study participants who did not receive the voucher. And we're doing this in both surveys, which we're collecting at years 2 and 4 post-recruitment, and with a whole host of administrative data sources. As Paula mentioned at the beginning, I'm currently trying to gain access to birth certificate data from the Michigan Department of Health and Human Services to look at birth outcomes. How do we recruit women into the study? So patients are recruited at Planned Parenthood of Michigan clinics by experienced NORC field interviewers. So patients come in for their appointment, and our field interviewer intercepts them after they've checked in. At this point, we ask them if they'd like to take a short eligibility survey. If they're eligible, they consent and then are randomized, where half of eligible participants get a voucher for contraception for the next 100 days. So the rest of the appointment proceeds as planned with no additional intervention from MCARES, except for the fact that half of the women received a voucher for contraception to spend as they see best. So who's our sample? In effect, our sample for this paper I'll be presenting today and also for the project overall. They are women between the ages of 18 to 35 years old, capable and at risk of having a pregnancy, so biologically fecund or having sex with men, not pregnant at enrollment, not wishing to become pregnant in the next 12 months, and have some out-of-pocket costs for contraceptives at Planned Parenthood. So what this means is these are uninsured women or women whose insurance does not cover the cost of their contraception. So we've had some changes in MCARE's eligibility over time. Initially, and at the onset of data collection, the voucher covered the cost of a Liletta IUD, which is the lowest cost IUD. It's the name brand IUD. So it covered 50% of the cost of name brand IUDs, which are more expensive, such as the Mirena, Skyla, and Paragard. We also did not enroll women who were below the federal, living at or below the federal poverty line, due to the fact that Title X funds at Planned Parenthood clinics completely subsidized their costs, in effect making our voucher useless for this population. And in early March of 2019, we learned that the Liletta was rarely stocked, so they didn't have the supply, or inserted at Planned Parenthood. What this meant was that although the voucher was intended to make the lowest cost available LARC free, the voucher was only covering 50% of the cost of available IUDs or LARCs. So we increased the cost, or we doubled the amount of the voucher during this time. In May, we ended randomization of non-clinician visits. And in early November 2019, Planned Parenthood withdrew from Title X due to the Trump administration requirements that organizations providing both family planning services and abortion, that they must physically separate these services. Planned Parenthood did not agree to do this, so they lost their 34B pricing and also the Title X subsidies. So while they adopted a new sliding scale with other funds available to them, prices increased for uninsured women, and women living at or below the federal poverty line between the ages of 22 to 35 started facing costs at Planned Parenthood. Most recently, we added the randomization of women seeking abortion on the day they enrolled. So you might be wondering, how do we determine the cost of the voucher? So you'll see that at lower incomes, Planned Parenthood and Title X funds cover 75% of patients' costs, and MCARES covers the remaining 25% of costs, making the lowest cost LARC available free, so that $123. As income goes up, Title X funds cover less, so MCARES subsidizes more, all the way up to us covering 100% of the costs for an IUD. Here's our 100% phase, where our voucher doubled in price. So as stated before, we learned the Liletta was rarely being stocked, so we increased the value to cover name brand IUDs, such as the Mirena, Skyla, and Paragard. This close to doubled the voucher amount for participants. And in early November, as stated before, costs increased by about 20% compared to the 100% period for brand name IUDs and LARCs. And women living at or below the federal poverty line started facing costs for those aged 22 to 35, so they became eligible for MCARES. In this paper, we are focusing on the study period prior to the Title X funding loss and policy change. So what is our analytic sample? We have about 7 months of recruitment at the 50% cost of name brand IUDs for a sample of 629, with around 300 in both the treatment and control groups, and around 7 months of recruitment at the 100% time period, with around 962, with approximately 500 in both the treatment and control groups. So what's our data? So we have the MCARES data. We have our survey 1, which screens on eligibility and captures basic demographic characteristics. Then we have our survey 2, which is our longer baseline survey, which women take right after their appointment or within 1 month of enrolling, which captures a whole host of other characteristics, marital status, fertility history, expectations, child background. So then we link our MCARES data to the Planned Parenthood Michigan billing records. This collects information on patients' visits, including their date of the visit, details, diagnoses, procedures, and this is actually how we measure our dependent variables in the analysis. We also use 2015 to 2017 NSFG data and 2018 annual report data as a benchmark for our MCARES sample characteristics, which I'll show next in our balance table. So you can see here that relative to the NSFG, MCARES participants are slightly younger and less likely to use contraception than the national sample of women in the NSFG aged 18 to 35. And compared to the national population of Title X participants, MCARES patients are similar in their use of birth control. This is expected given that both of these populations are women seeking reproductive care and services. And across the majority of our characteristics, you can see we have balance between the voucher and control group, as is expected with randomization. So here, looking at race, we can see that MCARES patients are less likely to be a racial or ethnic minority, and compared to Title X patients nationally, less likely to be Hispanic. This is most likely due to this group's underrepresentation in the state of Michigan, and less likely to be Black, given the fact that of their underrepresentation in areas served by participating clinics in our sample. We have some slight imbalance in both race and education, so we include these as covariates in our regression models. Finally, you can see that compared to NSFG, MCARES sample are more likely to have lower incomes. Again, this is reflective of the uninsured nature of our sample. And compared to Title X patients nationally, less likely to have income level below the federal poverty line. Again, this is due to women being ineligible for MCARES during this time due to having zero costs at Planned Parenthood. Again, we have balance between our treatment and control group, as is expected with randomization. So we estimate a reduced form effects of receiving a voucher for contraceptives using the following linear specification. So these intention to treat estimates capture the net causal effect of providing a voucher for women seeking reproductive health care, which can be used for, again, any contraceptive up to the maximum value of a 50% or 100% highest cost IUD. So what outcomes are we looking at here today? So outcomes are measured after the patient had been enrolled in the study, so post-recruitment for 100 days, when the voucher expired. We have a binary measure of whether any contraceptives were purchased. So again, IUD, implant, shot, ring, pill, patch, these are all included in this dichotomous measure. We then have a binary measure of LARC insertion, so either an IUD or implant. Again, billed after enrollment, and these are the most effective forms of birth control. We then have a continuous measure of expected annual pregnancy, which measure the 1 minus the CDC failure rate of the most effective method purchased. So in other words, this is the percent of women experiencing an unplanned birth during the first year of typical use of that method. So for example, an implant is actually the most effective method. There's a 5% chance of pregnancy within 1 year, whereas a ring has a 9% chance of pregnancy. We also measure contraceptive duration. So these are the days of coverage expected by a method purchased. So for example, a Loletta IUD or an implant are good for 3 years or 1,995 days, and a pack of pills is good for 28 days. We also measure the dollar value of contraceptives purchased. We create an index of these outcomes, which combines these 5 outcomes to summarize an overall effect of receiving a voucher. So this index helps us to increase power to detect same-size changes in efficacy across the 5 outcomes. So in order to provide you a benchmark for our regression results, here's a table illustrating how our 5 primary outcomes are distributed and differ between the treatment and control group. So we can see, compared to the control group, our treatment group has a higher proportion of any method purchased or LARC purchased, and a higher mean of the remaining outcomes. We ran intention to treat regressions for the full analytic sample, limited to 100 days post-recruitment, and we also ran long-term estimates which capture billing 2 years post-enrollment. We then ran intention to treat regressions separately by pre-specified subgroups and demographic characteristics. So by race, presence of children, pregnancy intentions and plans, etc. Again, just as a reminder, the intention to treat estimates were run for the full sample and by subgroup for the 50% period, where the voucher covered half the cost of the most expensive IUD, and the 100% period where the voucher covered 100% of the cost for the most expensive IUD. So the real goal of looking at these two time periods is to test how the magnitude of the subsidy matters for contraceptive take-up. So now into the exciting parts. How important are subsidies for contraceptive use? So here are our point estimates for the intention to treat regressions for the full sample by study phase within the first 100 days of enrollment. So overall, we can see that across all outcomes in both study phases, the treatment group was significantly more likely to increase their contraceptive efficacy. Tuning in here a little bit, in the 50% period, it reduced 1 year expected pregnancies by 17 points and increased contraceptive coverage by 194 days. If we look at the 100% period, we can see a larger magnitude where it reduced expected pregnancies by 21 points and increased coverage by 339 days. In the next set of slides, I will illustrate further how the magnitude of the subsidy matters for the 50 and 100% time periods. So I'm going to do this by dividing the voucher effect by the control mean and multiplying by 100 to show a percentage change. For example, for recipients with the 50% voucher, total spending at Planned Parenthood increased by 68%, so 199 over a control mean of 293. So here's our 50% phase. So we can see that compared to the control group, the treatment group significantly increased total spending by 68%, had a 35% increase in any birth control purchased, and 113% increase in both LARC insertion and temporal coverage. Adding in our purple bars, which shows us the treatment effect, we can see that overall, the 100% period shows a much larger magnitude than the 50% period across outcomes. So for example, we can see our largest gains in LARC insertion were making LARCs half-priced, increased take-up by 113%, whereas doubling the value of the voucher increased take-up by 342%. What this really highlights is that even at half price, so our teal bar there, high upfront costs of dissuaded many women from choosing LARCs. So to estimate our treatment effect beyond the first 100 days, we estimated long-term effects of the intervention using data obtained from Planned Parenthood in 2021. So what this analysis really aims to do is to understand whether this was, if receiving a one-time voucher really merely hastened purchases within those first 100 days, or fundamentally altered choices for a longer time period. So in the 2021 data, we capture about 27 months post-enrollment for the 50% group and an average of 20 months for the 100% phase. So again, these point estimates show that across outcomes in both study periods, we observe a significant treatment effect. Turning to the bar graphs, I show both the 50 and 100% groups again, where the treatment group remains highly persistent. We do see a slight reduction in the magnitude during this longer term period. However, these imply that they are still highly persistent post 2 years of enrollment. It's also noteworthy to say that LARCs were rare. LARC removals were rare during this time period and not statistically different between our treatment and control groups. What are the impact of subsidies by subgroup? So we ran a whole host of subgroup analyses, and I'm going to highlight just a few of them of key importance for you today. So across all subgroups, so across age, education, income, parenthood status, etc., we observe significant difference in our contraceptive outcomes. So compared to the control group, there is a positive treatment effect. However, we do observe heterogeneity by race and ethnicity. So we can observe here across outcomes that white women significantly increased their efficacy across outcomes. However, for the Black women, we find a negative or non-significant treatment effect for them. If you look at the 100% phase, we find that white and Hispanic women both had a positive and significant effect on outcomes. Again, Black women did not show an effect except for dollars charged. And what it really shows here is Hispanic women appear to be response to the voucher price and change, given that in the 100% period, they show significant effects, and in the 50% period, they do not. So prior to randomization, in the screening survey, we asked respondents, what do you plan to do at Planned Parenthood today? So if they selected, I'm here to get family planning services, we then ask them, what methods do you plan to get that day? Possible response categories were LARC and IUD. So among the 10% of women who plan to get a LARC, so our first bar graph here, in the 50% phase, receiving a voucher was associated with a non-significant 32% increase in LARC insertion. However, for the remaining 90% who did not plan to get a LARC in the 50% phase, receiving a voucher increased their likelihood by 182%. Adding in our 100% phase with the purple bar chart, we can again observe how the magnitude of the subsidy matters. So again, among those 10% of women planning to get a LARC, in the 100% phase, receiving a voucher was associated with a 135% increase in LARC insertion. For the 90% who did not intend to get a LARC, we see an increase of 362%. So what these results really illustrate is that making LARCs free allowed more women to either follow through on their plans, as observed in the 100% phase here, or caused others to change their plans. And what this may suggest is these high upfront out-of-pocket costs for contraception, for LARCs specifically, may be a barrier to use, but we removed this barrier with the voucher, which is why we may be observing this outcome. So we do have some limitations of this study. So the study population is limited to populations seeking reproductive health care, and we are not able to capture if respondents purchase contraception at other providers other than Planned Parenthood. Results are also limited to patients at Planned Parenthood health centers in Michigan, and so they may differ for higher income or uninsured women. What are our takeaway points? Subsidizing contraception allowed women to purchase more effective methods, especially those expensive methods like LARCs. And the magnitude of this subsidy, so the 50 versus 100%, really does seem to make a difference. So making LARCs half-priced increased contraceptive take-up by 113%, whereas doubling the size increased take-up by 342%. Our results largely held across subgroups. However, for non-Hispanic Black women, we see a smaller responses to LARC take-up and contraceptive efficacy, or no effect at all. And while these effects do attenuate slightly, they largely persist for 2 years post-enrollment, suggesting that these are just not short-term effects. So making contraceptive more affordable could have large effects on take-up and ultimately unintended pregnancies. I'm going to skip the updates on the project because I realize I'm running short on time, but we've got a lot going on here. We're continuing enrollment. We've gotten 2 more grants to study outcomes of children and women living below the federal poverty line. And we're currently administrating our year 2 follow-up survey where we're achieving excellent response rates. So as discussed at the beginning of my talk, my first area of research centers on studying fertility behaviors with a specific focus on unintended childbearing in the United States. I should say that these topics are highly aligned with the research priorities of the NICHD's Populations Dynamic Branch. So as Paula mentioned, my published and co-authored work to date has explored the determinants of disparities in unintended fertility. So key areas of research I would like to address moving forward are studying why socioeconomic and race ethnic disparities persist in a variety of fertility behaviors and outcomes. I have a secondary area of interest in how the intersection of paid work and family is associated with the well-being of couples and individuals. So what are some of the specific topics I'd like to explore? So given my primary area of interest in fertility, I have a set of MCARES specific topics I would like to explore. So the first being why we don't observe effects for Black women in MCARES. And there's a large body of literature showing different reasons that may explain this, and I would plan to test them. The second set of topics would be understanding how the effect of receiving a voucher in MCARES is related to longer term outcomes, such as family formation, perceptions of parenting, the intergenerational transmission of first birth characteristics, and labor market outcomes. The second idea I've been thinking about is wanting to study the measurement of unintended fertility itself across demographic groups with secondary data sets. So I would like to test how measures of unintended fertility, such as in the NSFG and PRAMs, and if these measures are invariant across social class and race and ethnicity. So given that there are differences in unintended fertility by race and ethnicity, and these differences are still not fully explained, I believe that measurement of the construct itself may be a part of the story. This research would help add to the current debate in the literature about the measurement of unintended fertility. And finally, given my second area of research in work and family outcomes and parent and child outcomes, I've spoken with PSC and affiliated scholars about possible projects moving forward. So specifically, my research interests in work and family and parent and adult-child relationships are really compatible with topics covered in the PSAT. I plan to pursue opportunities for data collection and analysis on these projects with Paula Fomby and other PSID investigators. I've also spoken with both Natasha and Paula about our shared interests as family demographers and the potential for us to collaborate on projects related to child well-being and family structure. And finally, I've spoken with Yasamin about our strong potential to collaborate on grant proposals given our shared research interests and expertise in fertility, contraceptive use, family formation, and the intersection of race and class. Thank you very much. And I would welcome your comments or questions. You can also email me after the talk using my UMISH email, or once we're all back in the office, feel free to stop in and chat with me. Thank you.
Thank you, Vanessa. That was a really excellent presentation. Do we have questions from the audience? You can raise your hand or post a question through chat or just unmute and ask. George?
Hi, Vanessa. So that was a fantastic presentation. I'm really impressed, and I think it's a great project, and I think your presentation was terrific. So the question that I expect everyone is interested in is the difference between, why is the behavior of the Black women in the survey different, and that's on your list of things to do. So maybe you're not ready to talk about it, but maybe as a way into that, you might have an answer to what might be a related question, which is, if you think, are there differences in the types of contraception that different women use that might be part of that? In particular, you focused today on the use of the LARC methods, but I wonder if you saw in your results any changes in behavior with other methods like the pill or whatever that were related to the subsidies that you didn't talk about here, and maybe what we're seeing is partly different cultural styles of using contraception. So thanks very much, Vanessa. This is great work.
Oh, well, thank you very much. Yeah, so I will just say I did really drive home our LARC estimates a lot, but our other estimates do include the pill. Now, we did not specifically run an outcome looking at, the dichotomous pill use or not pill use. So that would be a great analysis to run to see if we do pick up any effects for Black women. I will also say our sample size of Black women in the MCARES project is relatively lower than for example, for white women. So we're hoping with continued data collection, we can increase our sample size to see if we can at all start detecting something. Yeah, there's a whole host of reasons why money may not matter for Black women as much. They face different levels of discrimination in the healthcare system, or just the whole economic structure in the United States in terms of income differences disproportionately is different for Black women. So yeah, it's definitely something I'd like to explore moving forward.
Sarah Brugard?
Hey, Vanessa, great talk and great question. And I'm gonna just sort of add on to what George was saying in wondering a little bit about the power of a study like this to help us understand non-financial, non-pecuniary factors that might cause folks to have different attitudes about different kinds of medical intervention in their bodies. And as we all know, there's really good sociology on mistrust of medical systems that have oppressed and harmed populations in the US, and as is true all over the world. So it's interesting to think about whether or not you're picking up any of those kinds of things. I know it's in the residual, it's really hard to know what's going on in there, but I wonder, just given that y'all do actually enroll folks in person and so forth, if there's any opportunity to gather any other information that could allow you to understand some of the mechanisms underlying differences you might see that aren't about money, or that indeed are about money, and just the intersection, the interaction between racial identity and financial resources, that the same dollar amount could have very, very different implications for folks, as you alluded to. The third thing I would wonder is so I know that this is a very large study. Is there anything about the location of these women or the facilities that they're using that, I guess, I'm asking that boring old question about representativeness, but is there anything about sort of the way folks have encountered the medical system in the facilities that you're targeting that we should be thinking about in terms of whether this would scale to other facilities in other parts of the country or in other kinds of racially diverse populations across the US, for example?
Mm-hmm. Yeah, so I will say we have run fixed effects models, including the clinic where patients were enrolled. And we do find similar outcomes that I talked about here today. Yeah, I mean, I get right. So that is one barrier. In order to test a population and understand what's going on, you need to gain access to them. And we've actually done a lot of work to really try to gain cooperation at clinics like Detroit, where we've actually historically experienced a lot of just a hard time enrolling patients in this clinic. And so we've done a lot to try to build good relationships with the clinic, meet with clinic managers, build good rapport. So the hope is that, you know, we can continue to build these good relations to try to increase or boost our sample size to study this group, because I do think that, you know, we really want to see these effects, hopefully across all subgroups. And if they don't hold, what other systems are going on in this country that cause inequalities that maybe we can address? Is it about information? Is it about making sure providers and doctors are the same race as their, you know, increasing representation among providers in the types of care they give to patients or ethnic minorities? So all these types of things are things I've definitely been thinking about. Yeah.
Do we have any other questions or comments? Cynthia Buckley?
Yeah.
Oh, Cynthia, we're not able to hear you.
Yeah, here I go. Can you hear me? Please
Yeah.
excuse me, I'm moving. And so our internet is a bit spotty, so I'll be a phantom questionnaire. Dr. Lang, this was fabulous, and it was well worth taking a break from packing up to listen to this fabulous talk. And I was really struck by some of the similarities that you're finding with this voucher system, with, ironically enough, data from UNFPA in Uzbekistan, and the importance of getting rid of financial barriers for women's access, not just to contraceptives per se, for determining the contraceptive mix, to what extent are the financial barriers really driving the methods that women are employing. And I wanted to follow up with Sarah's insightful comment about the potential in the future to maybe add in to one of your two surveys of the respondents about have they negative misconceptions, so to speak, that's a very bad pun, excuse me, of particular methods, and to what extent might this be driving some of the racial and ethnic differentials? Yeah. So completely different world, completely different level of income, and completely different healthcare system, but uptake with LARCs is extraordinarily low among the Karakalpaki, because they see that as what the Uzbek government is pushing. And if the Uzbek government is encouraging it, then it must be dangerous and bad. So I'm curious, even just asking some basic questions about whether in their network they have a family member or a close friend that's had a negative experience with any of these methods, might be a quick and easy way to get just a first step towards unpacking that cultural box.
Yeah, I actually have done a little bit of exploratory analysis. So in our baseline survey, we ask questions about contraceptive attitudes. So whether they have negative or positive attitudes towards contraception. And I have just very preliminarily found that compared to white women, Black women have more negative attitudes in our sample, which I believe may be either a mediating or moderating factor in the relationship between race and contraceptive use. But that's a great idea to consider questions where you ask about a family member's experience, because that's how information travels, right? We share experiences, and that's what informs our decision making. So I really like that.
We also have a question from Elise Rattell.
Yes, Vanessa, thank you. That was wonderful. And I guess we're all focusing on this racial difference and ethnic difference that you found. Now, all of these I think what puzzled me is that all of these women are people who voluntarily sought services from Planned Parenthood. So they've already, in some sense, gotten over some basic level of mistrust of the system. So you would think that the Black women who show up at Planned Parenthood would be among the most open and most trusting. And yet you're finding this as well. One of the things that I'm wondering is the distrust of the medical system, or is it the distrust of the people who are interviewing them? Might there be another level of non-cooperation and mistrust? You mentioned that it was hard to get people to agree to be part of your survey in the Detroit clinics.
Right. Yeah, I mean, that's a good point. I think you're right. We definitely have somewhat of a selection effect in our sample, right? These are all women going to Planned Parenthoods. I will say that not all of the women were necessarily seeking contraception at their services. So, you know, Planned Parenthood provides pregnancy testing, breast exams, you know, all sorts of other services. But you're right, there probably is a slight predisposition among that population to perhaps be more positive in their contraceptive attitudes. But going back to your point about the surveyor, you know, we really tried to make an effort to make sure the demographics of our surveyors are matching those of the population that they're talking with. And so we, you know, the hope was to try to mitigate that somewhat, but I think you're right. You know, there might be more mistrust of like, oh, what's this study? You know, it makes me think of just, you know, the history of forced sterilization and all these things, that you might just have more mistrust of things like academic studies to be a part of, right? Or, you know, there's not just mistrust of the medical system, but of other types of institutions. So I think that's a really insightful comment.
We have another question from Sarah Burgard. You're muted, Sarah.
I just wanted to add to Dr. Atala's point, because I was reading a dissertation of one of our PhD students in sociology last night, and he wrote a whole dissertation about trust and racial differences in trust and generalized trust of people and in trust in different institutions. And so I strongly endorse the point that just in general, like general social survey attitude questions about like, do you think most people are generally like well-intentioned, or do you think you really can't be too careful with people? There are long-standing, very large differentials in by race in places like this area in terms of how just generally trusting people feel they can be toward participating in a survey or telling people what they really think or believe or plan to do and all of those things. So I do think, you know, there's definitely a lot of social scientific evidence to suggest that there might be like a average level difference. And it's interesting to try to understand how money plays into these choices, even when you have a self-selecting population that are arriving and wishing for certain kinds of reproductive health care already. So I just, yeah, and I think if you had attitudinal questions about different types of contraception, I think that there's, Liz Ela wrote her dissertation about some of this in terms of sort of how different groups view the trustworthiness of taking something inside your body versus using a condom and other things. And of course, women may also be thinking about protection from other things than pregnancy when they're choosing their contraception too. So there's a lot of pieces. I think we're all obviously like super interested in trying to unpack that black box of uncertainty about the mechanisms. But this is such a powerful design that usually we don't have this kind of leverage. So I think it's a real opportunity.
Yeah, agreed.
Okay, do we have any other questions or comments for Vanessa? Okay, if not, we'll conclude the formal presentation there, and I will invite our pre-doc and post-doc trainees to stay on for an opportunity to chat with Vanessa about her career. I think you've obviously seen that Vanessa recently graduated from one of the leading family demography program in the country, and stepped into a position where she's she's engaged in conducting what I'm hoping will be very influential research. So I think there's a lot to be learned if you're able to stick around and hear about Vanessa's experience. And I thank everybody else for attending. This is our last PSC Brown Bag for the term, and so we'll pick up in the fall and look forward to seeing you then.
Thank you very much.
Okay, Vanessa, do you want to stop screen sharing? Okay, and I'm going to stop the recording as well.